Hello, everyone. I'm Dr. Srinivas Chilukuri. I'm a senior consultant radiation oncologist at Apollo Proton Cancer Center. And we are observing World Kidney Cancer Day, which was on 17th of June. And there have been a series of discussions with experts who are called Uro Oncologists, who are supposed to be the experts in genitourinary cancers. And I've had four such interactions and discussions with them. And to summarize what we have learned so far, we all know about that there are two kidneys in the body. They are very, very important for the body to function normally. They essentially filter our blood and remove the chemical and metabolic waste which is generated on a daily basis. They also help maintain the blood pressure. They help maintain the number of red blood cells in the circulation. They also help maintain normal chemical and mineral levels in the body, which is very, very crucial, which is a fine balance, and the kidneys maintain that fine balance beautifully well. We know that cancers can affect essentially any structure or any organ in the body, and kidney is no exception. Fortunately, we have very good experts to deal with, and we had four such experts who told us that kidney cancers is not as common as breast, but it is not very uncommon cancer as well, which is probably the top eighth most common cancer is the kidney cancer. That's what was told yesterday. And he also told us that most of the cancers get detected when the patient is asymptomatic or has no symptoms. But for those who have symptoms, blood in the urine could be one of the first symptom. In fact, we were told that blood in the urine cannot be ignored and must be brought to a doctor's attention always. We also learned that there are three key risk factors for kidney cancers. One is smoking, obesity, and hypertension. Fortunately, all of them are avoidable risk factors. We can maintain a healthy diet and exercise and avoid obesity, avoid smoking. By maintaining a very good healthy lifestyle, hypertension also could be mitigated. There are medications to reduce hypertension, so it is controllable. But there are non-modifiable risk factors which are genetic in nature. That means there are certain group of patients who have altered genes or abnormal genes which could lead to certain cancers, and kidney cancers could be one of them. We were also told, we also have learned that ultrasound, a simple ultrasound, can pick up an abnormality in the kidney. And of course, that only will tell that there is some abnormality, and that needs to be verified, confirmed by a proper CT scan. Biopsy, which is done routinely, you put a needle and take out a tissue. That is commonly done in most cancers, but kidney, in fact, should not be done. Most cancers do not require biopsy, in fact, should not be done. There are multiple reasons which were enumerated. You could go in and remove the tumor directly. In fact, we were also told that there are certain groups of tumors and some group of patients in a certain age group, in certain risk criteria. We could even observe these tumors. We don't have to intervene and do a surgery. But if a patient does require surgery, in most situations, a partial removal of the tumor, and we can preserve the kidney, we can preserve the kidney function, we can avoid kidney failure because of removal. And we were also told that people can function very well normally with one kidney. We all know that. But in most situations for kidney cancers, partial removal of tumor, that means partial removal of kidney, could help in terms of it is oncologically safe and leads to a very good function. There are many advances in kidney cancer surgery which have come up. We were told about the minimal invasive surgery. We were also told about the robotic surgery, and we were told what are the benefits of robotic surgery, the quick recovery, the less blood loss, and so on and so forth. And to discuss further on this, we have one more prominent Uro oncologist in Apollo Proton Cancer Center, Chennai. He is also my colleague. Very happy to introduce Dr. Srivathsan. Welcome, Dr. Srivathsan.
Thank you, sir. Good afternoon to you all listening to this talk, and an excellent summarizing of the past 2 days of the talks that you have been engaging. An excellent summary, sir. Thank you.
Thank you. Dr. Srivathsan, our brief today is to talk about MDT. Can you tell us what is MDT and why MDT is important in cancers in general, and why MDT is more important in kidney cancer?
Right, sir. So MDT is an abbreviation for Multidisciplinary Tumor Board Meetings. So it is called by various terminologies at various centers. It started in the West, and now I think every cancer has to go through it. So what does it mean? It basically means that a group of clinicians associated with various specialties, whether it is surgical oncology or a urology, whether it's a radiation oncologist and a medical oncologist, radiologists who go through the CT scan, the imagings, and can pinpoint you what exactly is happening with that cancer, how to stage it, and so forth. So we all sit together in a meeting to discuss out on that patient what is to be the plan further in the future, whether it is pre-surgery, post-surgery. We also include the pathologist who can go through the biopsy report and tell us what exactly is happening to that cancer. Is it high-grade cancer? Is it a low-grade cancer? What type of a future planning has to be done for that patient? So when we all sit together to discuss a patient, this is called as a multidisciplinary tumor board meeting. It can be called by whatever name the institution wants to call. We at Apollo Proton call it a cluster MDT, where the specific organ or a region oriented specialist. For example, in urology, we sit Uro Oncology, the urology specific radiation oncologist, the urology specific medical oncologist, and the radiologist, and everybody sit together. We discuss out the nitty gritties of that patient. Now, the world is moving towards what we call as personalized care or individualized care. Not every treatment suits the general the public, or does it valid for every patient that we see on a day-to-day basis. And we are seeing more and more complex cases as the longevity has also increased. There are so many factors that we have to take into account in order to design a proper plan for that patient. So what we call as a individualized or a personalized plan for that patient. And this can be drawn only if all the clinicians who are involved in the care of that patient sit together and chart out a plan. For example, the age of the patient comes into the play, the various other comorbidities like diabetes, risk of renal failure, for example, very relevant to the kidney cancer patients. We do involve the nephrologist as well as to what would be the future in the progression of the disease, as well as in the treatment of the patient as well. See, patient is made up of all the organs, all the systems and everything. You can't just say that, okay, I'll treat only the kidney. So we do involve every specialty that is to be required for that individual patient, and then move forward in deciding what would be the most appropriate plan for that patient. And this is the way to go forward. And India has been a little slow in implementing. I do know that the various institutions in India do follow it, but I think in the future, every cancer patient has to go through some form of a MDT in order to make sure he gets the best of what is available at that point of time.
So basically, to summarize what you just said, we all sit together, and the collective wisdom of all the specialists who deal with this particular disease, in fact, taking help from, as you mentioned, nephrologist, and other patient could be diabetic, so we could involve the diabetologist, and so on, cardiologist, and so on. And we all sit together and we discuss what is the best line of treatment, and the follow-up, and the imaging, and everything else around the patient, which will take into account patient's expectations, patient's disease, patient logistics, and other factors. And we take a decision which is best suitable for that patient. And you summarize it very well.
Can I make a quote here, sir?
Yes.
We recently had a patient who has a left-sided kidney tumor.
Right.
Now, this patient was bedridden because she also developed a fracture of the femur, that is the thigh bone, which is most important for walking. And she was shifted from one of the other states from the Northeast to our center. Now, this is critical because there are two issues here. One, there is a kidney cancer, and there is also a metastasis or a spread to a thigh bone, which is the most important bone, and she has been bedridden for almost 2 months. So this again involved the involvement of the orthopedic doctor, the orthopedic oncologist, who looked into the metastasis. So we sat together, us, the anesthesia, the person who gives the anesthesia to the patient, the orthopedic oncologist, and the orthopedic doctor. We all sat together and decided what would be the plan for this patient. The question was, will she tolerate two procedures? If we are going to remove the metastatic by doing a surgery of the thigh bone, also we need to do the removal of the kidney cancer as well. So we sat together, we decided what would be the blood loss in each of this surgery, whether it would be feasible to do it along together, or should we stage the procedure and so forth. So we did decide that if the procedure for the replacement of the thigh bone is fast and less blood losing, then we will go ahead with the removal of the kidney, and which is what we did finally. But this kind of a discussion is very important because you need a plan, a map to understand. To give the best outcomes, you need to have a plan or a map. Without that, you're going to just hitting it in the dark.
So very well said. Dr. Srivathsan, another aspect of kidney cancers and as well as many other cancers is we've heard about chemotherapy, we've heard about treatments like targeted therapy, immunotherapy, radiation therapy. There are so many other therapies apart from surgery in various cancers. We all have heard of it. So my question is, are there any particular types of situations where we've already learned about surgery, but are there any situations when the surgery may not be the suitable factor, or you need some other treatments apart from surgery to make sure that the patient gets well, gets well? So are there any other treatments apart from surgery for kidney cancers?
Yes, sir. So there are two sad things that has happened over the COVID pandemic that has occurred, is that we are seeing more and more patients with advanced cancer of the kidney, even younger patients with advanced cancer of the kidneys. That's the main thing when it has already spread to other parts of the body, including the bone, the lungs, and the liver, and so forth. The second sad part about the renal cell carcinoma or the kidney cancer is that it is neither sensitive to chemotherapy, nor is it that sensitive to radiotherapy. Now, these two are very, very important tools in managing any cancer of the body, whether it's breast, lung, or colorectal, or things, other cancers as well. But when it came to kidney cancer, the main problem that the physicians who are treating the kidney cancer felt was that these two options were out. Now, the surgery was the single modality that was available some 2 decades ago. And there was one more modality called as a interferon therapy, which was not so effective. We did give it, but then it had a lot of side effects and a lot of issues associated with it. Neither was it so effective as well. But the last decade has been amazing with terms of management of kidney cancers. It has just evolved amazingly, and it's still evolving, to be fair. I mean, each month we have a new guideline which puts the first line, second line therapy, as you would know. So basically what has changed is that we have understood the molecular pathway which leads to the formation of the kidney cancers. Now, the current management, whether it is in kidney or any other cancer, is molecular management that we do at the both at the genetic level, at the immune level as well. So what are the advances that has occurred? See, we know why the kidney cancer cells multiply so fast, why it does not die early like any other cell in the human body. So basically it just stops dying. It keeps growing, multiplying. It lasts forever. And that is where they started thinking about it, and they decided that we need to cut the cell cycle down. And by doing that, we are basically cutting short the spread of the disease as well. So the first thing that came into the clinical practice was what was called as TKI, targeted therapy. So what is targeted therapy? Targeted therapy is nothing but we target certain level of cell cycle. That is basically we target the growth cycle of the cell, where we can put some blocks into this growth cycle so that the cell does not keep growing and spreading and so forth. So there are certain enzymes which are important for the growth of the cell. There are certain proteins which are important for the growth of the cells. If we can cut down this protein for that cell, then it is very well documented that the aggressiveness and the growth of the cell comes down and the spread of the cancer decreases. And this is what they did by introducing what was called as tyrosine kinase inhibitor, where there is a enzyme blocker which prevents the cell from growing and spreading. There is also a completely different viewpoint of therapy called as immunotherapy. Even the interleukins and the interferons that I was talking about is a type of immunotherapy, but it was a general immunotherapy. Now we have what is called as a checkpoint immune inhibitor. Now, what is that? Basically, we have two types of cells in our immunity. One is a B cell and another is a T cell. I mean, these are the cells which give you immunity against everything, infections, cancers, and so forth. Now, these T cells are very important because they are cytotoxic cells. Basically, they kill the cell directly or the bacteria directly by, either swallowing it or destroying it and so forth. Now, this gets modulated in a cancer patient because the cancer cells are also very clever. They produce certain protein which will inhibit these T cells, which will stop these T cells from attacking them. Now, what they did, the scientists did, was that they produced a molecule which will remove this inhibition of the T cells. That is, it will release the T cell into the circulation, which can again go and attack the cancer cells and kill them as well. So these are the latest drugs that we have, what is called as a immune checkpoint inhibitors. And these are amazing drugs. They are also known as the PD-1 or the PD-L1 inhibitors. And this is a very important, PD-1 is the protein which is important for the T cell to act. If PD-1 gets combined with PD-L1, which is the receptor on the T cell, then the T cells becomes inactive. By giving an inhibitor of this protein, we are reactivating the T cell. So basically, what we are doing is activating your own immunity in killing the cancer cells. We are not giving any cytotoxic agent, which is chemotherapy agents, which will have to attack the cell and kill it by itself. It is also a little harmful to your own normal cells because the normal cells are also gets affected by the chemotherapy. But these targeted therapies, that is the immune checkpoint inhibitors, reactivates your T cells. And by doing that, the T cell, that is your own lymphocytes, will go attack the cancer cells and kill them as well. So this is the two important advances that we have had in the last decade, which is amazing. And it has improved survival of the patient by so many years nowadays that we have had patients for the past 2 to 3 years who are still very happy on this medications. There are a few side effects associated with it, but then they are all quite good comparable with the efficacy with which it acts.
So you mentioned about targeted therapies, which are also been referred to as magic bullets.
Yes.
Also immunotherapy, you mentioned that immunotherapy essentially activates your own immunity to act against the tumors. Can you also talk about radiation therapy? Because radiation therapy is also, as you said in the beginning itself, that it is not sensitive to radiation therapy, the tumors. So do you think there is a role for radiation therapy as well?
Right. So to the primary tumor, that is the kidney tumor itself, the radiation doesn't do that great, and we hardly use radiation in those settings. But however, in the case of a metastasis, that is spread of the cancer, especially to the bones. Now, as I said, it is very notorious to spread to the bones as well. Liver, lung, and bones are the commonest sites where the kidney cancer spreads. So when it comes to bones, the radiation, especially the various type of radiation, which you will probably be the best person to decide as well, they are exceptional in giving low dose radiation, but at the still it kills the metastasis site at that point, like especially the vertebral column, the long bones, and so forth. And this goes a long way in establishing a control point, at least for that cancer spread. And it also, maybe even if you want to replace that part of the bone post-operatively, you can give radiation to the metastatic site and thereby improving the outcome as well as the survival. And obviously, see, when it comes to bone metastasis, the quality of life goes down a lot. And this radiation will definitely improve the quality of life in these patients. For example, bedridden patients who are, because of the vertebral metastasis and so forth, their radiation has a great role in, improving the quality of life of the patient. In the local cancer treatment, probably not.
Okay. So to summarize what we have just discussed, You mentioned that MDT, which is multidisciplinary management of all these cancers, is extremely important because patient is a person, a walking, talking person, has a different sets of problems, it has different sets of expectation, different sets of challenges, and all those things need to be accounted for when we are designing a treatment for that patient, and a multidisciplinary team will help take the decision appropriately and to ensure that we individualize the therapy. You also mentioned to us that there are certain type of treatments such as targeted therapy, which are specifically are against certain receptors or enzymes or proteins, which ensures that the cell cycle or cell growth is not at the same pace as the normal cancer cell is, and we try to slow it down and we reduce the chances of it getting spread, or it we reduce, if even if it's already spread, we ensure that the patient survives for a long period of time. You also mentioned about immunotherapy, which is essentially triggering body's own immunity to tackle the cancer cells. So, and you also mentioned that radiation therapy may not be as effective for the primary treatment, is effective in controlling symptoms when the disease is already spread. So, essentially, the kidney cancers, if it is localized, surgical options are the best options. And we have all learned about the advances in surgery. In situations where we know that the cancer is too big, it is difficult to do easy surgery, you could give something to shrink the tumor and then operate, or you could remove it completely and then post-operatively to avoid the cancers from spreading to other organs. We could give these newer therapies. If they've already spread, we could also try these therapies to prolong the patient's life and to control the symptoms. I think with this, we will have come to the end of the series of talks. Dr. Srivathsan, thank you very much for joining in and elaborating on all these key aspects of kidney cancers. I think we have learned how to diagnose kidney cancers, how to be aware of them, what are the common symptoms of it, what are the risk factors for it, how do we diagnose a kidney cancer, how do we treat kidney cancers, both with surgery. We have learned about the advances in surgery. We've learned about advances in non-surgical approaches as well to deal with kidney cancers. And we've also learned why multidisciplinary team will make an impact at most of the Apollo hospitals as of today. We have the infrastructure to manage very well these kidney cancers, and we will continue to raise awareness about kidney cancers in the common public so that we detect them early, as all of the experts have told us that if we are able to detect kidney cancers earlier, in earlier stages, we are able to cure them. We are able to give almost very high chances of cure to these patients. So with that, um, thank you, Dr. Srivathsan, again,
Thank
and
you, sir.
thank you the rest of the team for giving us the opportunity to interact with all of you and educating all of you about very important cancer, kidney cancer. Thank you very much.
Thank you, sir.